Right. So I think that with this setting, you see both me and my slides, right? Good. Okay. Welcome. Thank you for being here. As was introduced, I'm presenting this talk about a project that we did in the past couple of years about text mining for health knowledge discovery. And this was mainly the work of my PhD student. She has graduated in the meantime. Her name is Anne, and this is her picture. So let me introduce this. So little disclaimer. I know that the majority of the people here have quite some NLP knowledge, but not everyone. So there is some general introduction as well about the methods that I use, but mostly it's about this particular application. This was a joke, already 5 years old, but that I think was fairly typical if you think about rare diseases and people suffering from rare diseases. So a doctor might say, don't confuse your Google search with my 6 years at medical school, but then a patient with a rare condition might reply with, don't confuse the 1 hour lecture you had on my condition with my 20 years of living with it. And more and more it's acknowledged now that patients with rare diseases, with rare conditions, actually have a lot of knowledge about their condition, also from sharing their own experiences with that of others. This motivated a project to use information in patient discussion forums, discussion groups, to collect information about rare diseases, specifically rare forms of cancer. And there are many different things you could collect from those discussion forums, such as individual patient journeys, for example, which is relevant for a new project we're now working on, where I collaborate with Paul. But in this project, we specifically focused on like non-individual information, but more aggregated information shared between all patients about side effects that people experience, also called adverse drug events, ADE, and the coping strategies that patients have to deal with those side effects. We had a specific case here, and that is the case of a rare form of cancer called gastrointestinal stromal tumor, GIST or GIST. And we had a direct collaboration with the worldwide patient community for this disease. And here, the hypothesis was that real-world evidence from the patient forums of these disease can complement medical perspectives. So medical studies of the effect of medications. So as said, we had contacts with this patient group. It's really large, and it goes a long way back. From 29 until 2020, we had data, and this was over 124,000 posts in total in almost 15,000 threads, so discussion threads. And also, I think the posts were quite substantial in the sense there were a lot of posts that actually contain information, like the median length was 20 words. Of course, there's also a lot of, oh, wow, or, oh, I'm sorry, that kind of stuff, but there is actually a lot of content being shared. And when we started the project, we could still, within the laws, the GDPR at that point, and using the Facebook API, with permission from the admins of the Facebook group, they could donate us all the data there, of course anonymized, so all the usernames were not given to us, and as a trade we would then return with information for the patient community. So this was openly announced in the community that the data would be used for research, and yeah, that we would give updates on what we found. So there was one motivational example when we started this work. So one of the collaborators in this project actually is an active member of the GIST, the worldwide GIST community. He's a patient himself, and he was active in this community, but he is also a computer scientist. And he noticed actually that within the patient community, there was a lot of like useful experience being shared. And that experience was considered to be useful and also very often harmless, in the sense people were giving each other advice that could freely be followed, and that was also okay for doctors being followed. One example that he gave as a motivational example for this project was that when people suffer from nausea, when they take the medications for this disease, that it would help if they take the medication together with pure chocolate. So patients shared this with each other, had positive effects. And maybe it's good to note here that not necessarily this is like something that can be proven medically, right, physically. But it's not always a problem as long as the coping strategies are harmless and it helps for people. In which way it helps, it doesn't really matter. If it helps, then it might still be useful. So the idea here is, could we maybe monitor on the forum side effects and the coping strategies that people have, and thereby get more knowledge and information in addition to medical studies, post-market drug monitoring. Okay, so up until here, are there any questions?
Yes, there's a question from
Gloriana.
From Gloriana. Can you see that?
I can see it. I noticed that you saw it. Yeah. Gloriana.
Oh, hi. Yeah, sorry. I also put the question in the chat, so I wasn't sure whether you could read it there.
No, I could not see it there. Sorry.
Okay,
I don't see the chat, but I do see hands. Yeah.
Okay, perfect. So now I was just wondering if there were any reactions in the Facebook community on this announcement that the data would be donated for research, and if also people could kind of opt out from their posts being included in the research data set.
Yeah, so there were a lot of reactions. There were also a lot of not reactions. So the majority of the people did not respond at all. All the reactions that we got were all positive. We gave the opportunity to opt out, but no one did. So yeah, that went quite well. And I think that this community in that sense was very cooperative, and maybe more than many other communities would be.
Okay, thanks. Yeah.
Okay. So let me give a short introduction about medical entity extraction. The reason is that if we want to, from text, extract side effects and coping strategies, we're not classifying whole text. We are identifying relevant bits of information from within the text. And this is actually a machine learning task that is based on sequence labeling. That means that we're going to not classify a text as a whole, but classify each individual word. In that sense, that word order matters. So if a word belongs to an entity, depends on the word in the context. And very importantly, one entity can span multiple words. Like here, I have a throbbing pain in my head. Is quite a difficult way to say you have a headache. But it's multiple words, but it's all the same entity. It's all the same possible side effect. And there are multiple ways to refer to the same concept. And you can imagine that this is even worse when we are thinking about coping strategies. So if people are explaining what they do to deal with their side effects, that they even can use more different ways or longer stories to explain this. But because there are so many different ways to refer to the same thing, there's another task apart from extracting the entities, and that is to link them to a standard form. For example, in the medical domain, don't know if there are any medical people here, but we have the UMLS, a really large knowledge base of medical terms. And so here the word headache would be in there, and maybe some other terms to refer to the same thing, but definitely not all the ways that people refer to it in a text. So what we need to do is we need to label spans, like word sequences in a text that refer to entities. So here is a small sentence: pickle juice reduces my muscle cramps. And in this sentence, the green mark, the muscle cramps, could be the side effect, and pickle juice could be a coping strategy. So this is how that data is going to be labeled, and this is familiar to people who are working on named entity recognition. We label each word, where if the word is not part of an entity, it gets the label O, like reduces and my. If it's the beginning of an entity, it gets the label B, B coping strategy, B adverse drug event. And if it's inside an entity, it gets the label I coping strategy, I adverse drug event. So this is what the data looks like when training the machine learning model, the sequence labeling model. So if we're doing that, we need machine learning models that can actually take the context into account. And in the past, these would be hidden Markov models, conditional random fields, where in conditional random fields, you could actually enter features. You could describe words based on, do they contain numbers? Do they have capital letters? What words are they similar to, etc. Later, with the rise of the neural networks, we got recurrent neural networks, and bi-LSTMs were used the most there. But since 2018, 2019, almost all sequence labeling models have been superseded by transformer models, and mostly used are BERT models, bidirectional encoder representations from transformers. So the transformer is the architecture, and encoder means we're not generating text, we're only encoding text, we're only processing text. Right, so this is the type of models that we use. So let's apply this to our case here. Here we have the 125,000. I now realize this is not the exact same number that I had in my previous slide, and also that the decimal point should be a comma, but I think you get that. So out of these, so that's good to mention here. If you're going to use the sequence labeling models, it's supervised learning. You need to actually annotate data, right? And we had manual annotations, and here we also got help from people from the community. But we also had students involved here, and in total over 4,000 messages were actually manually annotated with side effects and coping strategies. With this, we trained our BERT models, and so when we apply that, we could get this information. So here I have a new type of entity, the blue one, that's the medicine. That's actually not very challenging, mapping medicine names to the ontology, to the UMLS. You have to deal with spelling errors and that kind of stuff, but still it's reasonably easy. It's typically only one word. So that could be done rule-based. So I'm not focusing much on that, but we do need that information, right? Because if we are collecting side effects, we want to know for what medication was this side effect. So here someone said, since I started on Gleevec, I can't fall asleep at all. The green thing here is a side effect, and it has to be matched to a normal form in the SNOMED ontology. And the normal form here for can't fall asleep is insomnia. So this is the official term. Of course, there are many other ways to refer to insomnia, and therefore this mapping is not trivial. And we used a model there, which is also based on transformer encodings. It's called BioSyn. right? So there are two types of models here. We have the model that extracts the entities, and we have the model that matches the entities to the knowledge base, in this case, SNOMED, which is part of UMLS. Any questions about this pipeline?
Well, there's no question in the chat. Can I just ask if the out of the 125,000 messages, only 4,000 something has the entities we are looking for?
No.
Is that what that means? Yeah.
No, that is what we annotated.
Okay, that's what you annotated. Okay.
Yeah, so we had 4,000. We had a sample of 4,000 randomly selected messages that we manually annotated.
Okay.
Right. Yeah.
Thank you.
No, we're getting to the statistics about how we found how much we found later. So no, this is the training data, right? So we need manually annotated training data to be able to train our models.
Yeah. Thank you.
Suzanne, what was sorry?
Yeah, go ahead.
Annotation. What was the kind of level of agreement that you got between annotators? Was that pretty good?
Yeah.
Pretty high?
It's in my next slide. It's in my next slide. Yeah.
Thanks.
Excellent question. Okay, so let's first look at the entity extraction. So here we focus only first on the side effects, which is easier than the coping strategies. And so what you see here is that recall was 74%, which means that of all the entities that were in the manually annotated data, the model identified 74 of them. And precision was 70%, which means that of all the entities that were identified by the model, 70% were correct. F1 is the average of that, 0.72. And we can compare this to the agreement. And this is, I have the same metric as the automatic evaluation metric for the human agreement, also F1, where we measure, where we take one human as the human and the other human as if that would be the model. And then we got a 0.8. So an NLP person would ask, why didn't you use Cohen's kappa for sequence labeling? That's a bit problematic because you have so many O's that the data gets highly imbalanced. So that's the reason why the pairwise F1 is a common way of doing this. So it was lower than the human agreement, but still, I think it was okay. And then the linking to the ontology. Here we have two metrics. So what we actually did is we ranked from the ontology the terms that are the most likely true entity where dimension refers to. So someone is saying, I can't fall asleep. And then what the model did is it returned 5 things ranked from the ontology that, okay, it might be insomnia, it might also be these other things. And then in 65% of the cases, the correct one was ranked at position 1. And then if we take into account the whole top 5, we get 79%. Right. Okay. So we now know how well it performs. It's not perfect at all. But the idea here was that we could still use it because we are aggregating over large amounts of data. So we might get noise, but overall the data together, we still might see patterns that are relevant. And indeed, this is the number of side effects that we found in the complete form, so with the automatic model. And so here, this is the most used drug. Gleevec is the brand name. I had that before. Imatinib is the medical name. And so that was the one where the most side effects were found for. In total, 21,000. Right, so this was already useful to the patient community, but of course they also want to know what the side effects were. So what we did, we had access to a previous survey that was conducted under GIST patients about the side effects that we have. And what we did was we didn't only look at the side effects that we extracted independently of other information, but we actually compared it to information that we got from survey data, so that we could find out if we actually in the forum find other information compared to the survey. So this is the comparison there. This is actually ranked. This is the side effects from the survey ranked by how often they were mentioned. And this is the side effect from the forum list ranked by how often they were mentioned. And colors indicate the same, the same item. So as you can see, there are definitely overlapping information, but there's also things that are, for example, on the forum, nausea is very highly ranked, and in the survey it was not listed there. And so there are some other differences that we think are useful, especially for the purpose of expanding answer options in the survey, for example. Any questions or comments about this first result?
No question in the chat. So.
Oh, Paul is raising his hand.
Gloria's hand is up. Gloria.
So
Gloria.
just a clarification question on the survey. So they had only like a limited list of options, or could they also add stuff?
Yeah, they could also add, but I personally don't know if to what extent the open answers were actually further processed. There were several explanations to these differences, and one of the things was indeed options missing in the survey. That was actually one of the things that we recommended for future versions of the survey to expand those. But also it seems that people on the forum feel more free to just complain about what they experience, and in the survey they are more tempted to only list issues that they think are more serious or that they think are worth mentioning as a side effect. Paul?
Thanks. So these are the top 10 in each case. Is there a long tail of these in the survey and or the forum information? Are you getting a kind of much wider set maybe from one or the other?
Not really, because it was normalized. So because we had the normalization to the ontology, to SNOMED, it's not really long tail. Of course, the actual entities that were extracted are extremely long tail, but when you normalize them, it's quite limited. Also, you can imagine that things like pain, they cover a lot of things. So this is also difficult here. I mean, here's pain in limb, that is more specific, is to what level do you aggregate or normalize the information?
Yeah, okay, thanks.
Then the next challenge was, so the conclusion was more or less, okay, side effects, that's doable. But this was actually a topic that was addressed.
I think there's another hand up, sorry. Michael.
Oh.
Yeah, I'm sorry. I'm sorry for kind of interrupting you. I was just wondering whether you had statistics about the distribution of those symptoms. Like, for example, does fatigue represent like 50% of the symptoms in the survey, and maybe only 10% in the forum, or something like that?
Yeah, I do have that, but not here. So it's definitely, I mean, this is a ranking, right? So
Yeah.
fatigue was in both cases the most mentioned. I don't know from the top of my head what it was. It was more than 10 and less than 50.
Yeah, no
Yeah.
problem. No problem.
So,
It's just, yeah. Okay, no problem. Thanks a lot.
Good. Right. So, but the side effects, the adverse drug events, that is actually a task that has been done before. These symptoms are already in SNOMED, so things like headache, fatigue, nausea, etc., are already listed there as symptoms. But when we move to coping strategies, and remember the example of the pure chocolate, this hasn't been addressed before. And currently this is considered more and more important by medical specialists. This very much relates also to the social emotional state of the patient. How can the patient be helped, not only be treated and medicalized, but also be helped more in general to feel better. So the patient well-being is very central here. But this trend is relatively recent, so there hasn't been any systematic collection about this. And again, here it's important that what we discover, what we extract, has two reasons why this is important. So on the one hand, it could help other patients, but on the other hand, it could also help doctors to figure out if actually something that is suggested is safe. So what if pure chocolate reduces the nauseousness from medication because it's actually suppressing the medicine, right? That would be wrong. So it's also important to extract this information to be able to inform doctors about, well, maybe advice that they have to give to patients, and don't listen if someone advises you to take pure chocolate because it harms your treatment, right? So that's another side of the coin, that it goes both ways. So we had these challenges of this rather new task. There was no data, so we had to annotate that. There was no ontology or knowledge base, in the sense that, of course, things like foods and drinks and activities are in the UMLS, but that is a huge amount. So everything that you could potentially drink or eat, or any activity that you could potentially undertake, would be possibly a coping strategy, right? So yeah, if you start with everything, that's a lot. Then these entities are very complex and have lots of different ways of being formulated. And there are these cross-document relations. So let me explain what that means. A cross-document, actually, it means cross-message. So one patient might say, well, I suffer a lot from my nausea. And then someone else might say, well, for me, it helps to drink ginger tea, right? So then, yeah, you don't have the side effect and the coping strategy in the same post. So, well, we had to start somewhere, and we decided to address this also actually after lots of considerations. So this was a point where we have all these discussions, Anna and I, about how to approach this, right? Is it more a classification task? Are we going to classify complete sentences? Are we going to link complete messages? But in the end, we decided to approach this also as an extraction task. And here you see the same kind of annotation again. So we have sequence labeling, coping strategies, we have adverse drug events. But now we created an ontology ourselves, and we linked the coping strategies to ontology items, to entities. So this ontology actually was built on the basis of existing ontologies, of course. So we got parts from UMLS, parts from SNOMED, and other sources. We filtered them for many different criteria, and then we compiled those together, and we gave everything a number, and that was the ontology we worked with. Oh, and there I have to mention that actually there are many more items in the ontology than actually in the data that you annotate, right? So if you are annotating a couple of thousand messages, then you might come across, I don't know, a couple of hundred different coping strategies. But in the ontology, we have tens of thousands different things, because every food is potentially a coping strategy, right? So yeah, this is challenging. So one thing that we did here is we not only looked in the ontology for the exact correct item, like something like blueberry juice, but we also saw, okay, maybe this was incorrectly mapped, but if we look one level higher in the hierarchy, it's still correct. So maybe then we could still have like berry juice mapped. So this is actually what we found, and as you see, the results are much lower than for the side effects. So here, if you look at the exact level of correct item, then recall was only 31% and precision even only 17%, which means that of the things that it's matching, only 17% was correct. If you go higher in the hierarchy, it becomes more, where precision even gets to be very high. But yeah, still recall is difficult. So yeah, this was a very difficult task. But still, again, we thought, well, maybe if we look at this from a higher perspective and we aggregate over a lot of data, then it might still be useful. And so here are numbers. We don't only have ranking, but here we have numbers. And actually, yeah, here was we had to deal with the long tail. So, and especially also low frequencies. And the reason is that the task is very difficult, and that means that the recall was far from complete. You're missing a lot, and precision was also low. So what we had to do, because of this low precision, was actually from the long list of things that we got, filter everything that clearly was noise or incorrect. So there were quite some cases where actually symptom itself was labeled as a coping strategy, for example. Or the medication itself. So someone is taking Gleevec, is experiencing nausea, and then actually the model thought that Gleevec was the solution to the nausea. Well, that wasn't correct. So we filtered everything that we could filter without any medical knowledge, just noise, right? And so here the idea was as well, well, this is something that we can use to support human experts, medical experts, right? We're not like bringing this into the world as the answer to everything, but there are some useful things here, and also some things that were mentioned often enough to maybe look further into by a medical doctor. So one of the things we already checked was ginger, which was both ginger ale, ginger tea, ground ginger was mentioned quite a lot. And we checked it actually with an oncologist we were collaborating with, and he said, well, yeah, actually patients have mentioned that, and it's completely harmless. So yeah, that's actually a good idea that we could say that we don't know if it works, but patients have experienced some positive results from using ginger. And here you also see that some of the coping strategies actually have to do with how to take the medication, like the whole dosage at once, at what time of the day, etc. Any questions about this or comments?
I broke out my mic. I don't know if you can hear me. Can you hear me?
Yeah, Mo, hi.
Oh, thanks. Just wondering, like when you talked about like the noise in the data set, and given that the whole discussion is actually about these kind of topics, like what makes them feel better and things like that, do you think that might have helped in reducing the lack of like bad results, if that makes sense? Because if this was like really open topics, I would expect it to like struggle a bit more, but maybe because it was in the domain.
Sorry, I couldn't hear a part of your question. So given that it was so noisy, would it help to, what did you ask?
Yeah, I'm trying to see if I can bring my mic closer. All right, so just wondering, because you said that like reducing the amount of noise might have helped in like getting better results. I'm just wondering, is it because the data set itself and the whole discussion is about like these kind of things, like what makes them feel like better and how they can cope, and then that's making like the coping strategy, let's call it like extractor, works better. So on the other hand, if this was like a very open topic, like including what makes people cope with strategy, but maybe also what people like to and shop. Would that made it like more difficult for the extractor in that case?
Yes, yeah, yeah. Actually, what I didn't present, but what we did do is we reduced. We pre-selected already threads in which we automatically identified with a classifier that there was sharing of personal experiences. So we had this pre-filtering based on that there was actually experiences being shared. So that already narrowed the search compared to having like all the chit-chatting in the collection.
Yeah, the reason I ask is because I've worked in these kind of things, not medical, but like something similar in the past. And then you would have to assume that the information retrieval system got you the correct data. So I think that's the same thing you've done here. So thanks for that.
Yeah, exactly. Yeah.
Okay, cool.
Right. So this is kind of where Anna's project ended. But I'm still, Anna is now working at the Forensics Institute of the Netherlands. So she's doing data science in a different context. I definitely want to continue with this, and it's really nice that this opportunity came along to participate in a project called 4D Picture. I don't know if Paul has presented something about that in the group, but the full name is Design-Based Data-Driven Decision Support Tools. It's about cancer patients, and it's coordinated from medical people, medical researchers, and they were interested in involving some actually NLP people and linguistics, which I think is really nice. And one of the parts that I'm working on is related to this project, extracting useful information from patient experiences. In the end, the goal is then to identify relevant care pathways for patients. So, as I said, my expertise, as was introduced by Ignatius, my expertise is natural language processing, information retrieval. So I'm not so much interested in this particular problem domain, but I am interested in the models that we can work with. And the first topic I'm now working on, actually a student is now working on that, is the entity ontology linking step, replacing biosyn by more recent models. Developments are going fast there. So here are 4 models: SEPBIRD was first, and BioCom, and CRISPR, and BioLord. These are all models that use transformer-based encodings to learn the connection between an entity and an item in the ontology, taking into account context, for example, taking into account having very few data points, learning also for other languages than English. So we're now looking into training one for Dutch, and I can imagine in a project later also for Danish. And we're evaluating that on various data types. So not only forum data, but also clinical notes, scientific literature, etc. And one thing that is very interesting now in the NLP community is that it has been shown that transformer models that don't even have an encoder, so that are only generative of nature, so only have a decoder, when they are trained on huge amounts of data, and this was first shown for GPT-3, but it's even more true for GPT 3.5 and the newer generation of GPT models, that they can do also extraction and classification tasks, even though they don't have like the encoder like BERT. And they can do it very few examples. And this kind of way of modeling with generative large language models is called few-shot learning. We only need a few examples. So I marked here the word open source. So one thing I know, I mean, people everywhere is now also working with GPT models, but OpenAI is a commercial company. Using their API costs money. And I would really encourage everyone to work with open source generative large language models, go to Hugging Face, get models from there that you can actually use on your own cluster, like Llama and Bloom, and etc. So that's something that I marked here. And also that is kind of a disclaimer for the next slide, because I did use ChatGPT for this example. So here what I tried is, so I prompted with our goal is to highlight medical terms in written patient experiences. Here are some examples. And then I got some, yeah, this is something I came up with myself also based on this presentation. I've cramps in my feet, the doctor says I have high blood pressure, things like that. And then I said, could you highlight the medical terms in the following text, please, using the bracketing like in the examples. And here's a real message from the GIST patient forum. You see it's quite noisy. And yeah, this was the reply by ChatGPT. So this task, yeah, it seems to at least partly do well. Next step would obviously be the linking, but I think this working with few-shot learning with large language models is definitely an interesting direction, because we're not always working in a domain where we have a lot of annotated data available. So that is actually my interest nowadays. So to conclude, patient forums are a valuable source of knowledge for experiential for experiences by patients, and extracting this information, side effects, and coping strategies can give us a lot of new insights and follow-up from medical research. Thank you. Yeah,
Yeah.
Paul. Yeah. Hi. Shall I share my
Thank you.
screen? Is that so that I can see everyone?
Yeah, if you want to. If people want to refer to any part of the slides while they're asking questions, maybe you can go back to the slides. Yeah, thank you very much for this wonderful talk. It's quite engaging, quite interactive as well. Are there other questions?
Yeah, I saw Mo had a question.
Okay, Mo, your hand is up. Yeah.
Thanks a lot, Suzanne. This is really interesting, to be honest. And it's been a while since I've been to an interesting talk, even online, about the combination between IR and NLP. And I think this is, as you said, it has to be done even a bit more on an open source level. My question is a bit different from this. So in the previous slides, you mentioned the you merge the ontologies. You talked about merging SNOMED with the others, but can you just tell us a bit more? How did that merging work?
Let me think. Yes, a little bit more, because that's actually what Anna did quite independently in the last year of her PhD work. What we did was, or what she did actually, together with students, she collected sources for this ontology. So she had some medical knowledge bases where potential coping strategies were in. Things like activities, foods, and yeah, other things that were already known. And then she started together with the students annotating bits of the form. And what they did is they tried to link all the coping strategies that they found to the ontology that was still under development. And then things were added when categories were added when it was not present yet in the ontology. So it was extended while the annotation was being done. And so there were several rounds of this and revisions. So it's not only merging from different sources, but also adaptation and adding categories. And then probably you're interested in how did you deal with discrepancies between the sources. And actually, I'm not sure. I think that maybe she only got part that were about different types of terms, so that they were not contradicting each other. Okay, because I was just thinking, does it go into a level base, try this one first, then the second, then the third, or is it all as one source? No. In how I remember it, there was one set of terms, and it was revised and extended during the annotation. Great. Thanks a lot for that. Cheers. Paul?
Oh yeah, thanks for the great talk, Suzanne. My question is similar to Mo's, I guess, a bit of a follow-up and also a bit of a kind of speculation on your thoughts on the ontologies. So we always kind of compare what we're doing against UMLS and SNOMED and others. but my impression is there's probably quite a lot of noise in those. And that maybe gives you a kind of ceiling for the task in terms of how accurate it could be as a maximum. And what's your kind of impression on those kind of things in terms of the noise or you know, the variety of expression in those ontologies?
Yes, definitely true. I think that there's a lot of noise in the hierarchy, for example, that is not always very consistent. And there's also, in my experience, also from previous projects, there is a lot of noise in which terms are contained and which are not. And sometimes something is in there, something else is not in there. You don't really understand why. So yes, there is noise. I think that in the end, the evaluation was done against what humans thought would be the best matching term from the ontology. But actually, now I remember, we also looked at cases where the model disagreed with the human, and there were actually quite some cases where it was not really wrong, right? So the matching was actually, I think, better than it sounds from purely the numbers. And this also has to do with this noise, obviously. So yeah, it's difficult. Ontology matching is a difficult thing. Yeah.
Thank you.
Any other questions? Okay, well, there's no more hands up and nothing in the chat. Can I just quickly ask, you know, the question I asked earlier about the post that you got at the ones you annotated, the 4,000, is there a criteria for selecting which ones you decide to annotate, or?
Yes, so we had this pre-filtering based on a classifier for personal experiences. So, I think there was also a length selection. So things that were extremely short or extremely long were also disregarded. But for the rest, it was random. But we had this classifier that said there might be a personal experience here. Yeah.
Okay, that's interesting. Thank you. Any more questions? Okay, if there are no more questions, we have to thank you again for a very wonderful talk and a very engaging topic. Everybody is interested in that. The recorded, we can have the presentation, right? The slides. Okay.
Yeah, I will.
So the recording will be put up on our YouTube in case you missed it, or you know anybody who missed it. We'll be advertising other talks that will be coming in the next few weeks after Easter and so on. So thank you all for coming. Thank you.
Bye.
Thanks, bye.